So now that we've talked about benzodiazepines and how they kind of fit into the treatment of anxiety, let's spend some time talking about maintenance therapy, specifically a lot of agents that we've already seen, but in a slightly different context. So in the utilization for anxiety and related disorders. So if we're considering how to manage these patients, particularly in comparison with patients using these medications for depression, they're generally going to need to start at a lower dose because of that acute risk or short-term risk of increasing anxiety. And patients will oftentimes end up needing higher doses to meet their efficacy needs. Just like with depression, but especially in anxiety, therapy is very helpful and appropriate throughout treatment for anyone who's capable of processing those therapy sessions. So that's really where you guys come in to do a lot of the work when it comes to treating these patients. So as a reminder, we have our selective serotonin reuptake inhibitors, or SSRIs, and these work by inhibiting the reuptake of serotonin in the presynaptic neuron within our central nervous system. So we're increasing the availability of serotonin in that synaptic cleft. They are considered first line for any of the anxiety and related disorders as a general rule. They're quite safe. They work relatively well, kind of a coin flip, 50-50, whether they'll work for patients first option, but they're pretty well tolerated. It is really the most commonly utilized class of antidepressant for these indications. Like I had said before, we do have to be cautious when we initiate therapy because of the risk of being activating or causing a short-term increase in anxiety upon initiation of therapy. And that's sometimes where benzodiazepines have a good place to help patients sort of bridge through that period of time where they may be more anxious from their medication. So if you look here, you can see the SSRI functions right at the serotonin reuptake transporter to block its activity, which increases the availability of serotonin in the synaptic cleft, which allows for efficacy over time. These are SSRIs. This just gives you a bit of an overview of the brand and generic of our SSRIs as review and their indications and how long they last in the body. Really the big thing about half-life here is that fluoxetine does last a really long time in the body. So sometimes that can be helpful for patients if they don't always remember to take their medication every day. So they're much less likely to experience a withdrawal type syndrome. If you see here, though, there's a lot of agents that only have one or two indications. So like Lexapro and citalopram only have depression, and then escitalopram has generalized anxiety as well. And then some have really paid pharmaceutical companies a little bit more money out to get additional indications. Like bulimia is unique to fluoxetine. And then paroxetine or Paxil actually has a number of different indications as well as sertraline or Zoloft. But in general, we tend to use them somewhat interchangeable. I'm less likely to use fluoxetine for our super anxious patients just because they're more likely to experience some of that activating sensation at the beginning and may not tolerate it as well, but it's still efficacious. Thinking about our adverse effects, they're going to be pretty much the same as if we are using them for antidepressant efficacy. So stomach issues like nausea, vomiting, and diarrhea. We can see some headaches, sleep changes, insomnia, or hypersomnia for some of the more sedating ones like paroxetine. Sexual dysfunction and that increase in anxiety at the initiation of treatment. They can cause some weight gain. Fluoxetine tends to be a little bit better for that, and paroxetine tends to be a little bit worse for that. We still have that risk of bleeding with these agents, particularly if someone's taking a lot of other drugs that are known to increase someone's risk of having a bleed, so just being aware of that, and dizziness. Moving on to our SNRIs, or serotonin norepinephrine reuptake inhibitors. These inhibit both the reuptake of serotonin and norepinephrine within the synaptic space. So this is also more specific and better tolerated in general than our tricyclic antidepressants, if you remember, because they also have those changes in our cardiac, so heart. They have antihistamine effects, which can make you sleepy. They dry you out. So they're a little bit less well tolerated. That's why we like the SNRIs a little bit better. These are considered for most the alternate first-line agents for anxiety disorders. The caveat to that would be PTSD, where venlafaxine is actually considered a first-line option for patients with anxiety that's related to post-traumatic stress. Our adverse effects tend to be similar to SSRIs, with the exception of they do tend to be a little bit more on the activating side. So they can sometimes increase blood pressure, make us have a little bit more difficulty sleeping, those types of things. But overall, about similarly tolerated. This is our mechanism of action. So if you remember, we have that SSRI type action here with the serotonin reuptake transporter, but we also have our norepinephrine reuptake transporter that's being affected, allowing for both increase in serotonin and norepinephrine within our synaptic space. These are our SNRIs. So we've got desvenlafaxine, duloxetine, venlafaxine, and levomilnacipran. Most of them, or really half of them, have just the MDD indication, but venlafaxine and duloxetine do have additional indications. Beware also, more of an interesting thing, that Cymbalta or duloxetine has a number of pain-related indications, so neuropathy, fibromyalgia. So it can be utilized in patients that are experiencing those types of pains as well. And sometimes we'll pick SNRIs over SSRIs if they do have something like neuropathy in addition to their anxiety. Our tricyclics can be used for these indications. So what we typically think of these agents as third to fourth line due to their tolerability and their toxicity. So they're much easier to have harm when you take an overdose. So we tend to avoid them first off. And particularly in our older patients, elderly patients tend to not tolerate these as well. But these work similarly to our SNRIs. So they have that norepinephrine and serotonin reuptake inhibition. If you look at amitriptyline, clomipramine, doxepin, and imipramine, they tend to be more lenient towards 5-HT or serotonin versus norepinephrine, and disipramine and nortriptyline are more likely to affect, to a greater degree, norepinephrine versus serotonin. These really do have a single exception to the rule of these are third to fourth line agents, and that's specifically with clomipramine in the treatment of obsessive compulsive disorder. So what's interesting about clomipramine is it's actually very much efficacious and is pretty close, is essentially in efficacy to our SSRIs. Really, the reason why it wouldn't be considered first line is because of tolerability. So clomipramine works quite well in OCD, as well as any antidepressant really does, but because it's not as well tolerated, we do have that bump down to second line. So as you can see, there's a little bit of extra activity here. So we have histamine and muscarinic receptors that are affected as well as our serotonin and norepinephrine reuptake transporters. So what that does is it gives us those additional side effects that we've talked about before. MAOIs are listed in a number of anti-anxiety guidelines and can be used, but are quite infrequently used. If you remember, these work by inhibiting monoamine oxidase enzyme, so MAOA as well as MAOB, which increases our monoamine concentration, so norepinephrine, serotonin, and dopamine. Recall those food interactions, lots of side effects, but we can use them in motivated treatment-resistant patients that don't like beer or chocolate. So these work more in a particular enzyme, so our monoamine oxidase, which breaks down our monoamines by blocking it. We are able to increase that concentration within the synaptic cleft. Okay, so we've talked about some review agents. I just wanted to talk about some extra stuff that you may have seen before, but maybe not, that are a little bit more specific to the management of patients that have anxiety and anxiety-related disorders. So buspirone, also known as Buspar, is a little bit interesting. It's a partial agonist at a specific serotonin subtype, so 5-HT1A receptor, although we don't really know how it works. Sometimes it is used for depression, but not very effective. So we generally stick with this as in clinic, like an add-on for second-line treatment in generalized anxiety. If someone has a substance abuse history, we can add this on, particularly if they're not able to use benzodiazepines for that concern. Although it does take some time to work, so these do need to be scheduled typically twice a day, and they do take a number of weeks, much like our other antidepressants do. The adverse effects are relatively well tolerated, so we have dizziness, nausea, and headache as our most common side effects that we associate with Buspar. Hydroxyzine, often referred to as Vistaril, is an agent that is actually just an antihistamine. So it blocks histamine receptors in the brain, which causes some central nervous system depression. So it kind of just makes you a little bit sleepy, calms you down a little bit. So it's a bit of a physiological anti-anxiety agent. It's considered second line for generalized anxiety, and what's nice about it is it does work very quickly, so you can use this as needed, unlike a lot of our other antidepressants, which need to be scheduled and take a number of weeks to work. So these actually will work within 50 to 30 minutes, kind of like our benzodiazepines do. They would have to be dosed multiple times a day if you wanted to continually treat them, so on a more scheduled basis versus as needed. We do use it with some frequency, though, particularly for patients that, again, we can't use benzodiazepines for one reason or another. It does cause that CNS depression. It dries you up, kind of like if you take a bunch of Benadryl. It dries up your nose, makes you pretty sleepy. So same idea here. But we can use it in patients that have that abuse history, as well as patients that may be having difficulty sleeping. Propranolol is a antihypertensive, so it lowers blood pressure. It does through blocking our cardiac beta receptors, which will actually decrease both blood pressure as well as heart rate. This is really utilized in patients that are experiencing event-related anxiety. So you take it beforehand, and it helps to decrease the sensation of that fight or flight response. So you're really lowering your heart rate so it can't pound out of your chest. You're lowering your blood pressure, so you're going to be a little bit less sweaty. You're going to be a little bit less worked up physically. It does lower blood pressure, though, so if you don't have high blood pressure, it can lower your blood pressure to the point where you might feel lightheaded. It can make your extremities feel cold because the blood starts to sort of go back into the center of the body to make sure that you maintain pressure there. And it can make you feel kind of tired. So people do take this a lot of times right before presentations, for example, and can be quite helpful. Prazosin is an alpha blocker, so it's also used in blood pressure, and this is specifically helpful in PTSD-related disturbances. So basically, it can block receptors in the brain to reduce that fear response. So norepinephrine activation within the brain is reduced, which allows us to feel less scared. This seems to be particularly helpful in patients that are experiencing nightmares when they sleep that have PTSD. Just like with our other blood pressure medication, it does lower blood pressure, and it can cause some drowsiness and dizziness as well. So we have to be cautious when we're increasing the dose because it can kind of knock people down a little bit when it comes to their blood pressure. There are a couple other agents that have some data to support their use, particularly our anticonvulsants or anti-epilepsy drugs. Basically, if you're reducing neuronal excitability, it can help tamp down the fear circuits, and we don't tend to use it unless we're mixing those agents with first-line agents like antidepressants. These are included here. So we've got pregabalin or Lyrica, valproic acid or Depakote, gabapentin or Neurontin, or lamotrigine or Lamictal. So you've seen some of these agents before. They can be helpful in things like social anxiety, PTSD, and generalized anxiety, but again, use in combination. So our basic algorithm here, we're going to start with an SSRI or SNRI plus or minus a benzodiazepine up to 6 weeks and then taper as our bridge. If we don't see a good response, we're going to switch agents. We can switch to another SSRI or switch to an SNRI. Switch again if they don't respond. If they're taking it, want to make sure they're taking it as well. Or start thinking about some of those alternative agents like Tricyclics. If they don't respond, we're going to probably keep them on an agent to avoid losing full response and add an augmenter, such as long-term benzodiazepine use or other agents like our anticonvulsants, propranolol, etc. Once a patient's had response, we will maintain them usually for at least 12 months, up to 24 months, and in some patients, if they have had a lot of episodes or have very severe anxiety, we might continue them on indefinitely. We're going to start. So in summary, anxiety disorders can be treated similar to depression with lower doses with slow titration. We might use our short-term benzodiazepines for severe anxiety and making sure that we keep those patients on the agents for the appropriate amount of time, especially things like benzodiazepines, as there is a potential for experiencing withdrawal effects. So please let me know what questions you guys have. I hope this was helpful for you, and thank you for watching.